Acute myocardial infarction is part of acute coronary syndrome and is the death or necrosis of cells in the heart muscle tissue caused by the arrest or decrease in coronary blood supply, ischemia, compromising various areas of the myocardium.
Classification. Type 1. Spontaneous AMI related to ischemia due to a primary coronary event. Type 2. AMI secondary to ischemia due to increased demand for oxygen or decreased supply due to coronary span, coronary embolism, anemia, arrhythmias, hypertension, and hypotension. Type 3. Expected death including cardiac arrest, frequently with something suggestive of myocardial ischemia. Type 4A. AMI associated with percutaneous coronary intervention. Type 4B. AMI associated with stent thrombosis, demonstrated by angiography or autopsy. Type 5. AMI associated with autocoronary bypass, subendocardial infarction of a segment of the heart that does not affect the full thickness of the myocardial wall. The term subendocardial refers to the fact that it affects the enormous layers, preserving the viability and functionality of the outermost layers of the myocardium. Transmural infarction that affects the full thickness of the heart wall. It is usually more extensive and with a higher risk of complication than its subendocardial infarction.
Talking about etiology, let's say that the main cause is advanced atherosclerosis and thrombosis of the coronary arteries, and rare causes are including embolization within the coronary arteries or embolization of fragments of arterial walls from aortic valve endocarditis. Coronary occlusion has also been described for a very long spasm of a coronary artery, and it's important to mention that genetic, obesity, and sedentarism can be related. Absence of aerobic reserve, acidosis, and so on. The contractile arrest occurs after several minutes. Then, the cell death initiates a wave of invasion of neutrophils and monocytes, causing acute exudative inflammation. This inflammation activates fibroblasts and endothelial cells, developing vascularized granulation tissue with the aim of tissue repair. The most frequent symptom reported is the precordial pain. A radiation of this pain to the arms, neck, and shoulders is also associated. The typical pain is a retrosternal pain of an oppressive nature, with irradiation to the internal part of the left arm or jaw accompanied by adrenergic symptoms, such as diaphoresis, feeling of evacuation, dizziness, and syncope. Nausea and vomiting can occur. In some patients, the presentation may be very atypical, even with dyspnea in patients older than 85 years.
Diagnosis. Acute myocardial infarction can be diagnosed using the following steps. Clinical picture. Myocardial infarction is recognized by the sudden appearance of the characteristic symptoms: intense pain in the chest in the precordial area, feeling of general discomfort, dizziness, nausea, and sweating. The pain may spread to the left arm, jaw, shoulder, back, or neck. Electrocardiogram. It's the definitive test to detect if you're having a heart attack. Records the electrical activity of the heart, and it's a simple and painless test. By analysis of cardiac enzymes. Total creatine phosphokinase that regulates the availability of energy in muscle cells. Lactate dehydrogenase that intervenes in the anaerobic metabolism of glucose. Aspartate transaminase that participates in the metabolism of some amino acids.
It depends on the duration of the hypoxonic episode. A reperfusion must be carried out mainly, that is, a reoxygenation if ischemic tissue. For example, use step-tracking to eliminate clots that occlude the arteries and administer oxygen. In the first instance, defibrillation and oxygen therapy. Anticoagulant, aspirin, clopidogrel, antiplatelets, heparin, narcotic, beta blockers, statin, morphine, angiotensin-converting enzyme inhibitor. Medical procedures: coronary bypass, percutaneous transluminal coronary angioplasty, procedures to open narrow or blocked blood vessels, coronary stent. Therapies: cardiac rehabilitation and improve eating habits.